Well, good evening. Thanks for coming out tonight. We've turned this thing down a little bit. Chase, can we go down just a little bit? Thanks. Before I start, for those Saturday morning, we're going to be doing a health fair at our church, at Olive Branch Baptist Church on Durgee Mine Road. So if anybody's out and around between 9 and 1, we're going to have the bus for the North Carolina Baptist men. So we're going to be doing, blood pressure, wellness checks, lipid profiles, hemoglobin A1Cs, and that's all free. So if you know anybody that might not be getting checked or needs access to health care, this is a great screening program. If you guys want to come out, this is all free. We're going to have basically a stew, free lunch around 11 o'clock. UNC Air Care's coming in to do a static display from 10 to 12. And so, I would welcome you, or if you know somebody that you think it would benefit, send them on out. We'll be there 9 to 1. So tonight we're going to talk about shock. Now, shock is what I had when Steve sold me my truck and I saw what the price of it was. But that's not the shock we're talking about tonight. People talk about shock and say, "Oh, I went into shock." There's emotional disruption, and then there's what we're talking about tonight, which is the physiologic disruption. And when we talk about the definition of shock, really the thing we learn is inadequate tissue perfusion. The bottom line is this. We've talked time and time again about what it takes our body to work. We need water, we need sugar, and we need oxygen. That's it. And if the cells aren't getting all three where they can produce energy, things don't work. So the bottom line of shock is inadequate tissue perfusion. We're not getting enough oxygen to the cells to let those cells metabolize glucose and function normally. So we talk about shock. There's shock that comes from low volume, hypovolemic, and that can be from simple dehydration, which we're going to see here a lot more in the flu season as it comes up. It can be from bleeding, from blood loss. It can be what we call distributive. That is, the fluid remains the same, but the vessel changes so that the patient might have an overwhelming infection, septic shock, or might have, we've talked about bee stings, anaphylactic shock. Very rare case, neurogenic, where they get a spinal cord injury. The heart can be not working well. Cardiogenic shock. Someone has a big heart attack, and all of a sudden the heart can't pump enough blood. And then something, again, is kind of rare, is obstructive shock. Things like cardiac tamponade or tension pneumothorax, a big pulmonary embolus. So we have really four types of shock: hypovolemic, distributive, cardiogenic, and obstructive. When we talk about shock, again, we're talking about the cells not getting enough oxygen to metabolize glucose. Therefore, they don't work well. And we are on aerobic metabolism, that is using oxygen. When they don't get enough oxygen, they switch to anaerobic. There are other pathways by which they can work, but they're not near as efficient. So you get less energy produced, you get more byproducts produced. It's like an auto engine that's just not tuned up and it's not burning fuel efficiently, and there's lots of emissions. It's exactly the same thing with the body. There's not enough oxygen, so the cells aren't working well, and the byproduct is lactic acid, and that causes metabolic acidosis, and when all that happens, potassium rises. So you begin this whole deadly cascade, if you will. But the biggest analogy is, yeah, it's just not a well-tuned engine. It's running on bad fuel. So let's talk about the four things that we need to work well together to avoid shock. The first is the pump, which is the heart, the lungs, where we exchange oxygen and take out carbon dioxide, the vascular compartment, which is the distribution system, the arteries, the veins, and then the fluid itself, our blood, of which we have 4 to 6 liters. So the heart's four-chambered organ. Atrium are the upper chambers, the ventricles the lower. When someone loses the atrial contraction. So the atria contract, force blood into the ventricles. Ventricles contract, force it from the right ventricle to the lungs, then back to the left atria, the left ventricle, out to the body. Every time the ventricle contracts, it squeezes out 60 or 70 cc's of blood. Well, how much is that? 30 cc's is an ounce, so a couple ounces of blood each time. But when you lose that atrial contraction, someone goes into atrial fibrillation, you lose about 25% of your cardiac output. The heart's surrounded by a really tight fibrous sac called the pericardium, and it's got a little bit of fluid in there. It's a lubricant, basically, and the heart squeezes it. If you get an inflammation of the pericardium, you get something called pericarditis. You'll get pain. When we've talked about heart attacks in the past, the heart is like any muscle. It requires oxygen to function. It requires glucose to function. So a lack of oxygen to a portion of the heart muscle will cause it to not function as efficiently as it should. So when you get, we're going to talk about cardiac, I think, actually next month. So let's say you get an obstruction of one of the coronary arteries and you get either angina or you get a myocardial infarction. So you knock off a portion of your heart. Now all of a sudden that contraction's not able to pump the 60 or 70 cc's each time. So that the heart has to function well as part of the system to keep the circulation. So what happens to the heart in relation to a state of shock? You typically get an increased heart rate. The heart tries to contract harder, so it's trying to pump more by pumping faster, pump more by pumping harder, and trying to increase cardiac output. Let's talk about the lungs. When we talk about the respiratory system, you contract the muscles of respiration, your chest wall expands, the pressure in the chest drops, air goes in. When you relax, the chest wall contracts, air goes out. What you're doing is you're taking in air that has about 21% oxygen, and you're exchanging it at the alveolar level. So when you take air in, the air goes in through the major airways down to the tiniest alveoli. Oxygen diffuses across into the blood, carbon dioxide diffuses out, so the CO2 is removed. And as you look at then at the lungs, when you disrupt that air exchange, either by pus in the alveoli in case of pneumonia, or you have pulmonary emboli where a certain portion of the lung may not be oxygenated, then you're decreasing the oxygen diffusing capacity of the lungs. So what happens with the lungs in response to a shock state? Well, you increase respiratory rate. Your body's trying to move more air faster, which increases the minute ventilation. That is how much we ventilate in a period of time. So the whole point is your body's trying to increase the oxygen delivery to the tissues. How about the vascular compartment? So we talked about the heart, we talked about the lungs. What happens in a state of shock with the vascular compartment? Well, in any stress environment, our body secretes epinephrine and other stress hormones, which tend to constrict the vessels. So as we do that, we try to keep our blood pressure up. So in a shock state, our vessels tend to, in many cases, dilate, which drops our blood pressure, drops our perfusion pressure. And again, we talk about delivering oxygen to the cells. If you don't have the perfusion pressure, you're not getting the blood, you're not getting the oxygen to the cells, and you'll end up switching to, as we said, anaerobic metabolism. When you do all this, the vascular compartment becomes leaky at the capillary level. Fluid escapes and bad things begin to happen. So what happens here? The vascular compartment tends to constrict, except in neurogenic shock. We're going to talk about that. What it's trying to do is increase the blood pressure and increase the perfusion pressure. at the cellular level, and our body's monitoring that through receptors, particularly in our carotid arteries. How about fluid volume? We all have 5 or 6 liters of fluid, the average adult. Red blood cells, the clear portion of the blood. We have always, historically, in emergency medicine, when we lost fluid, we replaced the fluid with lactated ringers or saline. And that's always been good for volume replacement, but it has no oxygen carrying capacity. The oxygen carrying capacity in us are our red blood cells. So when we lose red cells, we are decreasing oxygen carrying capacity. When we see patients in the emergency department, in the clinic, an example, we had a young woman come in a couple of days ago who had a viral infection, basically shut her bone marrow down. Her hemoglobin was 6. She's short of breath. Why is she short of breath? Well, she has half the red cells that she really needs. She doesn't have the ability to carry oxygen to the cells. So what happens in response to a shock state with our fluid levels? Our body tends to shunt blood away from non-vital organs. What are the vital organs? Well, the heart feeds itself first. The brain certainly is key, the nervous system. But it begins shutting down blood flow to the organs. That's why when you look at someone in shock, their skin is very pale. The body has shunted blood away from the skin. The kidneys begin to not produce urine. They're trying to hold on to fluids. We tend to notice that we're thirsty. Our body's saying, hey, we need more fluid to come in. So those are the things that you see early on, and that's why we monitor so closely urine output in trauma patients and shock patients. If they're making urine, we're doing okay, but when they're not making urine, that's the kidneys and the body trying to hold on to fluid volume. So blood, red blood cells, white cells, platelets is a very, very complex fluid. Has the nutrients, proteins, the antibodies. Plasma is the clear portion of the blood, but the key when we're talking about shock is the oxygen carrying capacity, which is done in the red cells. We have for years treated shock the same way, and it didn't matter what type of shock it was. We tended to stick big lines in people, and the bigger the line, the better, and give them lactated ringers. You know, the thing was 2 liters of LR. Put them on oxygen, get the blood pressure over 100. That was really the dogma for years and years and years and years. And then we judged how we were doing by looking at how their heart rate was doing, how their blood pressure was doing, put a Foley catheter in them, look at see if they're making urine or not. That started way back in the era of Vietnam and really continues somewhat to today. But then the thing that we have determined is that all shock is not created equal. When we talk about septic shock, for instance, the patient is losing fluid into the third space, that is the soft tissues, out of the vascular compartment. So giving a lot of fluids makes sense, but when you're talking about blood loss, giving just lactated ringers doesn't make as much sense because you're getting a lot of complex changes and inflammation is going on. Anaphylaxis is not treated the same, anaphylactic shock, as hypovolemic shock from bleeding or neurogenic shock. So really it becomes, we know that we have to get the cells perfused, but how we do that varies from the cause of the shock. We talk about trauma, for instance. I think we all have seen it. If you say, what's the leading cause of trauma deaths, it's typically neurogenic head injuries, would be number one. But, 40% or so of those deaths are caused from bleeding, massive bleeding. And in the 60s, the Vietnam era, LR became the standard for managing hemorrhagic or hypovolemic shock. And it was taught through ATLS for years and years and years, like get big lines in, get the 2 liters of crystalloid. And I think many of you who have as much gray hair as I can remember the days in trauma care where we packaged patients at the scene, and you wanted the patient properly boarded, and you wanted the lines in place, you wanted everything going before you transported. And then the studies started coming out where the patients who got flopped in the back seat of a police car and taken to the emergency department had better survival statistics than what we were doing in the field. So a lot of the stuff that we identified really came out of the Vietnam War. And it was the first time that we had taken well-trained medics, much as many of us were trained, and put them out in an environment where they had things that they could do. But in that era, pushing clear fluids for trauma was what we did. And they began identifying something called Da Nang lung, which subsequently became known as adult respiratory distress syndrome, where the patient initially does well, and then they get in trouble from a respiratory standpoint. If you take a chest x-ray, it's just a whiteout. And basically, it's inflammation in the lungs and fluid in the lungs. And it's all because of cellular swelling, too much clear fluids. We've disrupted the clotting factors and the clotting cascade. And that really was the 60s, the 70s, and the 80s. So now, really, the last 10 or 15 years, a lot of other strategies have emerged, including one of the things which we do here is TXA. So things have changed in the treatment of shock over the years, but clearly the leading edge, the research was back in the 60s and 70s with what came out of Vietnam. I mean, the fact is most of us here who are or were medics are medics because that was something that was developed in the Vietnam conflict and then brought home to this country. And once again, for those who watched the show Emergency in the 70s, that was a direct shot of an offshoot of the development of paramedic programs in big industrialized cities, all out of the Vietnam conflict. So we talk about how do we diagnose shock? What are we looking for? As just so much that we talk about, it's the little things early on that tip you off that something's wrong. So a patient might, let's say they've had diarrhea for a few days and nausea and vomiting, and they're a little tachycardic and they're really, really thirsty. You know, their blood pressure might be fine. If you wait till a patient is hypotensive to diagnose shock, you're way behind the curve. You're really looking for the early signs. You know, that patient whose heart rate's a little fast, you know, the heart rate should be 70 or 80 in most of us, and maybe it's 100, 105, 110. They're really thirsty. Their mucous membranes are a little dry. Might be confused. But the point is, blood pressure is later. So what the body does in regarding blood pressure, let's say this patient's normal pressure, and they know it is 110/70. And you check their blood pressure and it's 105/90. That pressure has narrowed, the pulse pressure has narrowed. So the body is stressed where the systolic's dropping, and because of the outflow of stress hormones, the vascular's constricting, so the diastolic's rising. So again, little tachycardia, narrowing of the pulse pressure. Those are all early. When you begin getting in trouble, you begin shunning blood away from the non-critical organs. The skin is non-critical, so you might get a little pale skin. One of the things that is key when you look at patients is pull up the sheet, pull up the legs, get the pant, look at their legs. And if you see that modeling, that blanching of purple and pale skin, that's because the patient's either not getting enough oxygen or not getting enough fluids to the cells. And as you watch that modeling, as the patient starts with modeling distally down in the legs, so they get worse, it just moves up. And so if you get someone with modeling to their waist or up to their chest, you can see that change as we resuscitate them. So when you talk about how do we diagnose the general signs, you have thirsty, altered mental status, little fast heart rate, Decreased blood pressures later on. Skin color's key, and the patient's sweaty. Why they're sweaty? Sweat is due to sympathetic outflow. We're stressed. The sympathetic nervous system is working overtime, so we're going to get diaphoretic. So when we talk about hypovolemic shock, low volume shock, what are the causes for it? Well, fluid loss of any reason. You'll get cool, clammy skin. They're pale. It might be diaphoretic. We just talked about altered mental status. You push, obviously in kids, we want a capillary refill of less than 2 seconds, but you can look at the same thing in adults. You go pushing on fingers and toes, and it's a slow capillary refill. That's consistent with decreased perfusion. Bleeding from trauma. We've talked about all the various causes, ballistic injuries. You put yourself of our colleagues in Vegas a couple weeks ago. You talk about all the victims and the thing. I have a friend who was working the night shift at the medical center in Vegas that night. And, it's something where, I don't think any of us can imagine what that scenario would be like. And obviously the victims are recovering, but the caregivers are as well. All of a sudden you're faced with people who, who are bleeding out from ballistic injuries. And we've changed the thoughts there from we were used tourniquets, we went away from tourniquets, we're back to tourniquets for extremity injuries. Stop the bleeding. GI bleeders. We see all the time. People are throwing up blood, they're passing black stool out the bottom. Ruptured abdominal aneurysm. The thing when you talk about bleeding internally, young female with sudden onset of abdominal pain, shocky symptoms, you have to think of ruptured ectopic pregnancy. Patient, and we're coming into cold and flu season, and they get nausea, vomiting, diarrhea, and they start throwing up and start having watery diarrhea, and they get thirsty. Well, those people can get hypovolemic and basically can go into shock from dehydration. The bottom line is there's just not enough fluid in the body to perfuse the cells. Our goal, really, in the pre-hospital phase is it sounds simple, but stop the bleeding. I mean, that's number one. Everything else is secondary. When we talk about how do we stop the bleeding, we know it's pressure. We know it's pressure points. We've gone away from tourniquets. Now we're back to some really cool pieces of equipment. But if you look at what every combat medic has, they have a tourniquet in their bag. If they have an extremity injury and they're bleeding out, put a tourniquet on it. We'll worry about saving the limb later. We got to save the body right now. So we want to stop the bleeding. And really the critical phases in pre-hospital care are stop the bleeding, get the patient to a trauma center. We talked a few minutes ago. Scoop and run is better than packaging and waiting. And I've been in an EMS system where we did both. I mean, it was just amazing back in the 70s how the expectation was that you stayed at the scene and you packaged and you did all this stuff. Those patients weren't doing very well. So now it's like we understand that the survival statistics are better getting to a trauma center, getting the IV started en route. We also understand that simply putting 2 16 gauges in and starting to open as much lactated ringers as we can run in quickly is not the treatment of choice. So now we talk about using small boluses. We're trying to keep the patient from developing metabolic acidosis. That is, we're trying to perfuse the cells while we also don't give so much clear fluid that we're knocking off clots from where they formed and we're causing disruptions in the coagulation cascade. All these patients need oxygen. We want to keep the SATs above 95%. But the key thing is recognize the cause, get the patient to a trauma center, and begin the resuscitative measures en route. The big thing that's changed in the last few years has been TXA. And it's interesting the way this medicine works. If you looked at the cascade of clotting, we give TPA to break clots up, and it works at a certain point in that cascade. We give TXA to stop clots from breaking down. Our body breaks clots down. It does. When we develop a clot somewhere, that's to, the body immediately begins trying to dissolve that clot. Well, when we give TPA, we're trying to speed that process up. We got a clot in the heart or a clot in the brain. We're trying to break it up. With TXA, it's just the opposite. Body's formed a clot. We're trying to keep it from breaking that clot down. TXA does not cause you to form clots. If you got no clots, it's not going to make you have them. It's simply going to stop the ones that are there or slow down the breakdown of those clots. So, and it's fairly cheap compared to most of the stuff we use. It's like $50 a vial. So it's been used in combat medicine for some time. It's used in a lot of surgical cases right now. It does require the system interact with a trauma center. So we've put all that in place. And it really is just one of the changes that have happened in management of shock over the last few years. So again, doesn't cause clotting. It doesn't cause pulmonary emboli. It doesn't cause deep venous thromboses. Doesn't do any of that. It just simply stops the clot breakdown. And you're saying, well, what's it do? There's something between a 1% and 2% reduction in trauma deaths when this is used. And that doesn't sound like a lot, but that's a pretty big number when you talk about the patients that are benefiting are the sickest patients. But again, like many medicines, it's got to be started quick, first 3 hours. It's got to be followed up at the trauma center. So hypovolemic, dehydrated stock, get oxygen in. If it's just simple dehydration from gastroenteritis, from throwing up, from diarrhea, getting saline, getting lactated ringers in is fine. 1 to 2 liters. Watch the heart rate. Check blood sugars. When you go giving a lot of fluids, blood sugars can drop with that in some cases. Distributive shock is something that we see in particularly, I'll give a case of elderly who are really, really sick. Septic, for instance. The vessels have dilated. The fluid volume is the same. If you got 6 liters, 6 liters is still there. It's just that the vessels have dilated. Now there's just not enough fluid to fill the vessels. So you've got decreased resistance in the vascular structure. As just like in a fire hose, if you're pumping the same pressure at the pump and the same volume, but you put it in a bigger hose, then the perfusion pressure goes down. You put it in a smaller hose, the pressure goes up. And it's exactly the same in the body. When you dilate those vessels and use the same volume of fluid, the pressure drops. The pressure drops, you don't perfuse the cells. It's just that simple. So let's talk about sepsis. Those at risk, as you would expect, sepsis is an overwhelming infection. Bacteria cause this diffuse inflammatory response. Can come from any number of causes. When someone comes in elderly into the emergency department, into our clinic, and you're thinking sepsis, there's really 2 places you look right off the bat: urine and lung. I mean, you can go 99% of the time, you're going to find the source right there. Either they got a urinary tract infection or they've got a pneumonia. So those that are at risk for getting into trouble, diabetes complicates everything. The elderly, those over, I hate to say it, 65. Pregnant folks, history of alcohol abuse, HIV disease, liver disease, anything that causes immunocompromise. So we talked about pneumonia and urinary tract are number 1, number 2. People can get infected gallbladders, can get really, really sick from that. Major abscesses in a lot of cases, particularly with pelvic abscesses, perirectal abscesses that might be associated with the bowel. Get infections in the abdomen. People who have indwelling catheters, whether they're urinary catheters or peripheral or lines that got infected. Anybody who's had recent major surgery is at risk. So these are folks you got to think of when you're talking about septic shock. The difference in we talked about hypovolemic shock, well, the patient's temperature is normal. The thing in septic shock is that the temperature is abnormal in most cases, but it can be high or low. We think, well, you got an infection, your temperature is going to be over 101. Well, it can also be low, and you get septic. You can drop your temperature and actually become hypothermic. You'll check, one of these little elderly folks, they came from a nursing home, they got a big urosepsis, and their temperature might be Fahrenheit 93, 94, as versus what we normally think it might be, 102, 104. It can be either. Heart rate's fast, respiratory rate's fast. Most of these folks have altered mental status. Again, what we talked about, fluid resuscitation is key. These folks get crystalloid. They all get oxygen. The key to sepsis is getting antibiotics on board quickly. And this is one where we've all seen it, and it's not pointing fingers, but a patient goes to a clinic or goes to an emergency department, and they're going to get transferred to a higher level of care because management needs. So antibiotics don't get given at the first place. Patients transferred to the higher level of care. Then they go through the whole process, and maybe it's 2 or 3 or 4 hours. Same way in an emergency department. Patients determine they're going to be admitted. They don't get their first dose of antibiotics in the ED. We'll get them when they get to the floor. That could be 6 hours later. So the key in sepsis is identify the source, get antibiotics on board. Ideally, as caregivers, we would have gotten cultures, either cultures of the urine or blood cultures or whatever. But the key is rapid antibiotics. So particularly when we're transferring a patient from a local facility to another one, they may well be getting their antibiotics en route, and that is perfectly appropriate. We've talked about anaphylaxis several times in our various lectures, but it's something that we see more during the warm weather months. But you've been exposed to an allergen. The patient reacts. They react typically with hives and itching. They get peripheral vasodilation, blood pressure drops, heart rate increases, they start wheezing, they're getting in trouble. We've talked and talked and talked. What's the cornerstone of treatment for anaphylaxis? Well, the pointer doesn't work. It's number 3. It's epi. So all these other things we're talking about, septic shock, get them on oxygen, get them in fluids. Hypovolemic shock, get the lines in, small fluid boluses. TXA if it's from bleeding. In anaphylactic shock, epinephrine is the key to treatment. Yeah, you support the airway. You get the antigen away. If they've got latex exposure, if they got a bee stinger in place, absolutely. But getting epi, and it's not sub-Q, it's IM, that's a mistake there. But get the epi on board while you then begin starting the IV and doing the other modalities. So epi, start the line, get them on oxygen, repeat the epi in 5 minutes if you need to, get the steroids on board, get the Benadryl on board, get the Zantac, Pepsid, whatever else on board, but it's epi is the key to survival in true anaphylactic shock. We don't see this very much, and I have to tell you, I don't know that in 30 years in the business that I've seen 1 or 2 cases of true neurogenic shock, because it comes from basically severing the cord somewhere above T6. And all you're doing, or what you're doing is you're knocking out the sympathetic nervous system. So the body has no ability to, your body's stressed, but it has no ability to transfer the neuro impulses which cause the vessels to constrict. So there's no fight or flight response. We don't have it. So the vessels can't constrict, but our skin color is normal. Heart rate many times is normal, but the blood pressure drops. So you've basically done is the vessel is dilated, the fluids remain the same, but we can't respond with our typical fight or flight response. So it is a rare kind of picture, but it's due to typically cord trauma. So these patients may have, they'll confound you because their skin's pink and it's warm and they're not diaphoretic. Why are they not sweating? Talked about it a minute ago. It takes sympathetic nervous system to cause you to sweat. You just knock that out. They got decreased blood pressure. They're alert. Their capillary might be fine, but but they're hypotensive. They're not perfusing well. So heart rate slows down, skin's warm and dry, tissue perfusion suffers, and it's all because the vessels are dilated and the sympathetic nervous system's knocked out. So immobilize the spine. We've talked about selective spinal mobilization, just immobilizing the part that is injured. We know that patients laying on boards for hours at a time don't do well. Get them on oxygen, get the fluids in. These patients may require pressors such as dopamine, keeping them warm. They can't maintain their body temperature now, so we have to help them maintain their body temperature. Cardiogenic, we probably see more cardiogenic shock than we know. And typically these patients are ones that have an anterior wall MI. So when we talk about the heart, we talk about circulation of the heart, the right coronary artery, it's the right ventricle and kind of the bottom of the heart. And the left anterior descending coronary artery gets the front of the heart, which is primarily involves the left ventricle. The left ventricle is where we get our ejection fraction primarily from. So if you have a big lesion that knocks off, say 40% of the left ventricle, all of a sudden you don't have the cardiac output. Your heart simply can't get enough blood out to perfuse the tissues. And so these patients may have had the sudden onset of chest pain, and all of a sudden their pressure is 60, and you put them on EKG, you see an anterior wall infarction, you've got cardiogenic shock. Vessels are okay. There's adequate fluid. The pump is what's not working. And obviously these are ones that need to get to the lab, to a major center right away. So these folks, as is typical of shock, will have cool, clammy skin, might be pale and cyanotic, rapid heart rate, low blood pressure. They're having chest pain, acute MI, and all the things we see with shock, but their problems come from the heart. So what we need to do, we need to get them to one of the big centers where they can undergo a revascularization procedure. There's other causes. MI is the big one. Patients typically 7 to 10 days after a major MI are at risk for rupture of their septum or rupture of the ventricular wall. Again, pretty rare. I saw it once when I was a resident. The guy was 7 days out. That's when they were still in the hospital a long time. He suddenly died. The post-mortem is, you have a soft spot where that infarction occurred and it ruptured. So you had myocardial rupture. Valvular insufficiency. If you have an aortic valve that gives out, all of a sudden, there's just really no control of the pressure going out or coming back. So bottom line is heart problems, big heart problems, will cause cardiogenic shock. So what do we do? Oxygen, CPAP may help, small boluses of IV fluids, pressors, antiarrhythmics off to major center. We talk about the last kind, obstructive shock. We're talking about obstruction to blood flow. So the vessels are fine, the pump's fine, the volume's normal. But for some reason, our blood flow is obstructed. And so these are folks that typically show a rapid heart rate, maybe trouble breathing, short of breath, they're anxious, and then as things go on, they start dropping their blood pressure and perhaps getting altered mental status and cyanotic and so forth. Tamponade is something we don't see a lot, but someone gets hit in the chest, major trauma, gunshot, ventricular eruption. Some infections can cause fluid buildup around the heart. And when you see the old days, we would see pulseless electrical activity. And so you see a rhythm, but the patient's got no blood pressure. One of the treatments was to stick a needle in the heart and see if you got fluid return. Pretty rare, but it happens. The one that is common is pulmonary embolus, blood clot to the lungs, particularly a big, what we call saddle embolus. If you look at risk factors for pulmonary emboli, someone who's got a cancer somewhere. Any cancer causes clotting disorder, and these patients are subject to develop clots in their legs, which go to the lungs. Young females on birth control pills who are smokers, high risk for PE. Whenever someone gets a PE, we start going through this thing. So, all right, and the question would be, all right, you got a blood clot in your leg, you got a blood clot in your lung. Have you, for instance, been on a long trip? You've been on an airplane the last couple of weeks. Well, why that? You're on an airplane, you cross your legs, one of the circulations kind of gets cut off, you fall asleep, you spend 2 or 3 hours like that, you got a clot that's developed while you're there. Have you been in a car and you haven't taken a break every couple of hours? So when we're all traveling, we need to get out of the car every 90 minutes to 2 hours and stretch our legs. And the joke in mind is, yeah, get out and knock the clots out of your legs and get back in and go again. But it's the truth. So, hey, you've been traveling. Are you a smoker? Young female, are you on a birth control pills and smoking? Have you had an injury to your leg? Maybe a couple of weeks ago you whacked on the leg and had a big bruise and you kind of been favoring it. Now the underlying vessel has gotten inflamed and you've got a blood clot out of it. So those are the things we start looking at. Someone may be immobilized. It's something as simple as they're in a short leg cast or a walking boot and they're not up moving around. And they sit around all day and you put their leg up and they get a clot in their leg. Then the clot moves, it breaks loose, it goes to the lung. A big clot will go to the lung and sit at what we call the saddle, where the pulmonary arteries branch, and all of a sudden the patient gets chest pain, they get short of breath, and it's not coming from the heart. The heart's straining, trying to pump blood against this big clot, which is obstructing the outflow. So they get chest pain, they get short of breath, they drop their blood pressure. Their right heart's the one that's strained because it's trying to get blood to the lungs, and it's being obstructed by this clot sitting there. So overall cardiac output goes down. What do we do in the field? Well, you have to think of it, but the treatment's, IV, oxygen, monitor, get them to the hospital. They're going to be diagnosed at the hospital, one by history. Typically, CT with contrast is going to be the gold study, but there are other, echoes and things that can be done quicker. So, enough to have a seizure doing that. The thing that we do see, so we talked about obstructive pulmonary embolus, the thing that we do see are tension pneumothoraxes, which can cause obstructive shock. Whether it's traumatic or atraumatic, we've had a couple tension pneumothoraces, and it's typically the same body build. Someone's kind of tall and thin, and all of a sudden it's like, I woke up 4 o'clock this morning with shortness of breath, and they come in and there's no breath sounds on one side. Well, you know what it is. It's a spontaneous pneumothorax. The question is, how much tension is in there? So what happens is that in a closed chest with no wound, no opening to the outside, something in the lung pops, a little bleb, whatever. And every time you take a breath in, more air goes into the chest cavity and starts compressing that lung until finally the lung is completely down. So as that air builds up in the chest cavity outside the lung, it begins building up pressure and it begins compressing the vessels, particularly the veins. The vena cava is very, very thin vessel, easily compressed, and that's what happens. So you've got pressure building up in the chest, the return blood flow to the heart is decreased, the patient feels short of breath. You listen, there's no breath sounds. If you got a lot of tension, you'll start seeing the trachea deviated. So if the tension pneumothorax is over here, the trachea kind of moves this way. Because the veins are not able to empty completely, they start getting neck vein distension, for instance. Needle decompression is the treatment, particularly if we're out here in the country, and that's the thought. Simply sticking a needle in the second intercostal space is going to let the air out. Patient's not going to like you for sticking the needle in, but they're going to feel a whole lot better when the lung comes back up. So the take-home point from this is shock is complex. All shock is not the same. Recognizing inadequate tissue perfusion early on is key to what we all do. So you look for the cause, you manage the cause, and you get the patient reversed, you're trying to prevent with resuscitation metabolic acidosis and cellular damage. That's it. 46 minutes. What questions can I answer? So again, anybody that wants to come out Saturday morning, if it's you or a family member, and get your A1C and your lipid profile checked, the bus will be at Olive Branch Baptist Church on Durgee-Mine Road, just down the street from the Triple Springs Fire Department. Will be there 9 to 1. Hopefully, if the weather's good and there's not a lot of calls, Air Care will be in and doing a static display. You guys are welcome to come out. And the thing is, so come get your cholesterol checked and go down and have some stew. It's perfect. Maybe go out back and have a cigarette after. I'm kidding.